Hello all. My lecture today about the ultrasound-guided cervical extraforaminal pulse radiofrequency and steroid injection. All the doctors working with pain management know the cervical radiculopathy, which is a pain perceived in upper limbs caused by irritation of the cervical roots. The majority of the patients coming to the pain clinic of the cervical radiculopathy because of the cervical disc prolapse. Some of the patients have spondylosis, some of the patients have osteophyte, and some of the patients have, for example, superimposed by diabetic polyneuropathy. But the majority is due to the disc herniation, presentation of the radiculopathy or the patient coming from paresthesia, weakness, pain, and majority of the patients have cervical radiculopathy improved within 1 or 2 months by conservative treatment or anti-inflammatory or muscle relaxant. So what is the selective cervical root injection, blocks or pulse radiofrequency? So allow the further pain control after failure of the conservative treatment, we need to skip to another modality to treat the pain of the patient. So most of the patient, after 2 or 3 months from the conservative treatment and back to surgery or unfit for surgical interference need some pain control. So here this is the rule of the selective root nerve injection or pulse radiofrequency. So you can do this block in outpatient or inside the theater. Previously, this is block done by a fluoroscope or by a CT imaging guidance. Now the use of ultrasound in guiding cervical nerve root block was initially described by Galliano and et al. In cadaveric studies in 2005. The objective of this review is to evaluate the effectiveness of ultrasound in facilitating the cervical pre-radicular corticosteroid injection to control pain in patients with cervical radiculopathy that is resistant to the conventional medical treatment. So, briefly about the pulse radiofrequency neuromodulation of peripheral nerve that we use combined with the steroid injection. We use also the peripheral nerve pulse radiofrequency. For the pain management, it's the placing of the needle electrode near nerve and generating electrical current pulses in order to modulate the transduction of the somatosensory information through those nerves. This technique evolved from the similar of radiofrequency procedure with constant current distributed to the nerve, and then it's interrupt the nerve conduction or the pain conduction and prevent the somatosensory information from reaching the brain. So here, this is briefly the catastrophic complication reported during the CT or fluoroscope. During CT or fluoroscope guided transforaminal cervical root injection, described injuries include the brain infarction, spinal cord infarction, and death. During the procedure, the intima of the vertebral artery can be punctured and injured and leading to the dissection. A proposed mechanism to explain injury to more proximal central nervous system structures include embolic microvascular occlusion from particulate corticosteroid. So this is one of the causes in many countries now stop the steroid injection, cervical steroid injection, because of the complications or fatal complication occur. And this one of the complications is microvascular occlusion from the particulate corticosteroid. And that eventually injected into the vertebral and intracranial circulation. Similarly, it has been postulated the occlusion of the spinal radicular artery also occur, and particulate corticosteroid are injected intravascularly, and that lead to the spinal cord infarction also. So a lot of complication here reported by CT or fluoroscope guidance cervical. So many countries or many centers stop the cervical interference because of the fearing from the complication. So here, just we want to talk about the superiority of the ultrasound guidance. Here, in my practice, We exceed more than 1,000 plus cervical intervention by steroid and radiofrequency. So the rare complication noted because the injection is deposited to the lateral part of the cervical foramina at the level of transversal process. It is not transforaminal injection. It is lateral to foramina. So this is called extraforaminal cervical root injection. So this improves the safety level without compromising the efficacy of the pain relief. She has et al. Also reported no complication with the CT or fluoroscope extraforaminal injection. So this is the same here. This is the idea, the main idea, to put the local anesthesia or the steroid or any injectate just extraforaminal, not intraforaminal or transforaminal. So this is the guide to put the needle extraforaminally, just lateral to transversal process, and the posterior tubercle, and then you can inject or hydrodissect or modulate by pulse frequency. It is superior than transforaminal injection or put the needle inside the foramina. So here you are away from the radicular artery, you are away from the vertebral artery, you are away from the spinal cord, and this is the superiority of the ultrasound. So by the CT scan or by the fluoroscope, it is so difficult to find out the existing foramina or existing root. So you need to inject the dye, you need to take a lot of exposure to reach to this level and then to continue your procedure. But by ultrasound, we also will see that in videos, and after these slides, you find it's very easy to detect the extraforaminal and very easy to detect the nerve and then to inject around it or to hydrodissect that depends to the pathology. So here, unlike fluoroscopy, the comparison between the ultrasound and the CT scan, the ultrasound does not expose the patient, as Dr. Bar said, to radiation. There is no requirement to perform the procedure of radiation, shielded room, neither need to wear X-ray or Google's or imaging can be performed continuously. So the sonographer watches the needle at all the time during advancement, and the fluid injected is mostly visualized in real-time fashion. So the vertebral artery is also visualized using the Doppler sonography, and also the risk of intravascular injection of the local anesthesia of injury to the vessels is avoided. So the procedure can be performed by ultrasound so safely by skilled hand after training, so it will be very easy. So this is the briefly about the, you can see the pointer. Okay, so here this is the foramina, and this is the posterior tubercle, and this is the anterior tubercle, and this is the C6 level or C6 vertebrae. You can see the proximity of the carotid artery, and you can see the needle here, and this is the nerve, and this is in the cadaver or in the real models. You can see the existing roots. So we take this view, lateral view here of the foramina. So here this is the part, medial part of the transversal process, which is close to the vertebral artery. It is the anterior tubercle, and the lateral one, it is the posterior tubercle, and the root is existing from the foramina to go to in between two muscles, scalenus anterior and medius, to form the interscaleal space. So here this is the existing foramina of the C6 root, sorry. So here you can see also in different, it does depend to the patient anatomy. Sometimes you see different height of transversal process or the lateral or tubercle. So the aim is to put the local anesthesia or the steroid or whatever you need to inject here for the pain modality is just around the nerve when you visualize the nerve, not inside the foramen, because here the acoustic shadow of the bone will prevent you to follow up your injectate or solution. So here the guide is to put the nerve before the nerve go to the to be outside, because here you can catch the dorsal root sometimes. because here you are so close to existing to the dural sleeve. So here you can inject, the injected can go inside, and sometimes you here block the medial branch also of the facet joint, and here you can also block the dorsal branch also, not just the ventral branch, and the femoral reef will be augmented by just. So to be just close, put the needle in this angle in between the bone and the nerve, and this is here you can visualize all the vascular structures and every dangerous structures surround the nerve. So here you can see in some patients the vertebral artery in its groove. So the vertebral artery is very close to the anterior tubercle. So I recommend it to put the needle in the lateral aspect or in the lateral part of the nerve and posterior tubercle, and to be away from the vertebral artery puncture or dissection or injection inside. See here, this is the fluoroscopic guided selective cervical root. We can see here the doctor or the professor here using the fluoroscope, different view, different position, and then with the needle, maybe he's so close to the vertebral artery or close to the anterior tubercle, and then inject the dye, and to diagnose this is the existing foramina. So this is from my work. I'm using this the catheter. This is the multiple level selective cervical root. I use it for the multiple levels or for the sometimes for spinal cord stimulation. You can see the catheter here, and you can see the root here. It's a selective roots. You can see here this is the T1 root, C7, CS7, 6, 5, 4. So I reached to the C4 roots by the single injection here. But this is the catheter. It's in high skull hand, and it is so costly, and with all the procedure here, you need a definitive or pathology or disease to do this selective. This patient have myelopathic spinal cord because of the multiple disc prolapses, and the patient need pain control and also for stimulation of the roots for the motor and sensory. I want to show you the videos about some videos about the Here we will demonstrate the existing foramina of the cervical roots from the C2 to the T1. The patient have good height of the neck, so from the everything. We can start here from the. You have the patient have, so this is the good height. This is the first root, this is the T1 root. You can see very clear. And this patient I cut also the T1. And this is the level. First from the neck. Which is a very high neck. Here you can see here, this is the C8 root. So you can see this is the posterior root. You can see the C7 root, just the posterior tubercle here, and the root in the artery and the C7. And here you can see the C6 root, the posterior anterior tubercle, and the existing foramina. You can see here, this is the fifth root, cervical, C5. See the different shape of the posterior tubercle. Each level has its own shape. The C4 root. So this is the root now. This is the root. And this is the tubercle here. This is the root, and this is the facet. So the posterior anterior tubercle and the C4, this C4. And here you can go to the C3 root. When you go more proximal, it's difficult to visualize the nerve. You go to the C3 root, and this is the existing form, this is the anterior root. And here you can go finally to the C2. In the C2 you can see the vertebral artery. And this is the existing form, and here the vertebral artery very clear.
And here, this is the C1.
C1 no roots. You can see just the bone.
I'm sure how to find it, now this is here the area of supraclavicular block, and this is a clavicle now, necropharyngeal area. And see here this is the clavicular artery, and here the CH1. I will emerge.
See the junction of two roots. This one and this one. This is the
CL, and this is the T1. I will show you the root. See, this is the CL, go, and followed by the T1 to convert together to form
the lower triangle.
And here, this is the brachial plexus, and this is the subclavian artery, pleural, first look. If I go more above, I can find just this is the see the middle here.
Here I will stimulate the C1,
this is the T1.
This
is the pleural.
To see the movement, conformation of this,
and this here.
You are in the CH1.
Subclavian artery, lower trunk, and my needle here. This is the needle.
So the pleural is so close, the vessels here so close.
Is the needle here. See, here on the supraclavicular area. Okay, now I will show you how to stimulate the T1, T2. See, تعصابيات. Good.
So this is the
CH, T1, T2.
I will show you another video about how to do injection around the cervical root.
وفيه هسه انا بصور سنتين مصاب العصب الزنجي عندك؟
Video, so this of tomorrow. Sounds survival. We haven't. لا مشكلة أنا سلفات الفيلم
Okay, this is the number C5 root. See the root here. Okay, this is the number C5 root. See the root here. This is the root, and this is the foramen. This is the needle, this is the root, and this is the foramen. Now let's complete the C5 root. I found here the root is injured by surgery, and now the
C5 root, you
can see this is the root, this is the fibrosis around the root also, and this is the existing foramen. This is the foramen, posterior and anterior tubercle, and the middle and the root. Now you have the dissection to the root. Allow. Okay, this is the non-C5 root.
Yeah, this is the position, the patient in the supine position, and the leg is lateral, and
the root, and this is the
let's see the The foramina here, so this is the tubercle, this is the posterior.
This is the needle, this is the root, and this is the foramina.
Posterior tubercle, anterior tubercle, and here this is the vascular structure of the carotid and internal vein. This patient had cervical surgery. After surgery, developed the nerve injury, causal GA because of the fibrosis, the lesions around the nerve. And here is just to release the nerve from the fibrosis around it, and then you can see how the nerve here is passing from the foramina, and the needle here, you can see the injective here, and see the thickening. This is the white hyperechoic. It is the thickening of because of the surgery, because already this is the surgery. So here you can see the thick tissue around it because of the fibrosis. Very hard, thick tissue around the nerve because of the surgery. So, okay. Thank you. Any questions?
Any question?
Cervical? Generally, some cases or some intervention, for example, sacroiliac joint. I put by ultrasound, clever probe, I put the needle inside the sacroiliac joint after identified by ultrasound, and then to confirm by fluoroscope. Because any bone structures or any target in between bone structures is very difficult to be sure you are inside by ultrasound. You need to confirmation by the fluoroscope. Sometimes, as Professor Bayer said about the lumbar also. In my practice, I taught my resident or fellow how to do transforaminal injection by ultrasound, not for the final procedure, no. Because I want to save the time, radiation exposure. So when I teach my resident to put the probe in the L4, for example, to identify the vertebral body, existing foramen, transversal process, and put the needle here and just reach to the foramina and then stop and put the ultrasound away and bring the fluoroscope, and here you can find out you are so close to the foramina. So to put the needle tip in the foramen, inject the dye to see the roots and then complete your procedure. So ultrasound here is aided, guided and aided to fluoroscope to decrease the exposure. But some procedure like cervical, definitely no rule of the fluoroscope of my practice. No rule of fluoroscope or CT guidance, because in cervical you can do all extraforaminal from the C3 to T1 by ultrasound, no need any fluoroscope. Thank you.
Sure. I have one more question. Actually, I really appreciated your presentation.
Thank you.
I wonder why we should do the pulse array for the cervical nerve, because I think that like that where it happens, where the pain is generated is the place where the herniated disc compressed the spinal nerve. But and I see that we do a corticosteroid injection to the extraforaminal, and we can think that the injection of the corticosteroid disperse the compression of the nerve to the site, but we do also the pulse array. How can you explain the mechanism of the pulse array?
Thank you. Here, the steroid effect here is for the as anti-inflammatory, because you know the herniated disc, the extruded of the disc, the irritation, irritant materials is exposed from the disc, like prostaglandin, like alkylonic acid, like histamine. It's ruled out by the steroid. But here we are talking, and the fibrous tissue also by hydrodissection and release the nerve. But here we are talking about the chronic pain. So the best physiologically management for the chronic pain, it is pulse radiofrequency, because here it do like mild ablation to the C fibers, firstly. Secondly, we go to the gate theory that pulse radiofrequency enhance the inhibitory neuron to projection in neuron and the dorsal roots ganglion. So here to stop the pain pathway from the peripheral structure to the brain. So here the pulse radio frequency combined with the steroid for different purposes. This anti-inflammatory, hydrodissection, release the nerve, clean the area from the inflammatory cells, and the radio frequency for physiologically of the pain pathway from the peripheral structure to brain. So this is the combination of pulse radio frequency with the steroid will give you, in my practice, the cervical injection with pulse radio frequency giving me at least 1 to 2 years pain relief for 90% from my patients. I have a very busy pain center in my region, so I follow up my patients. I'm a resident also, and we see after introduce the pulse radio frequency with the steroid, we got very long period, more than 1 or 2 years. Previously 6 months just with the steroid. So here this is another issue. I just put it the radio frequency here just to my lecture because the title of my lecture the steroid pulse radio frequency for extraforaminal. So
have you come across any complication after the procedure?
no, thanks again. No.
If I may, just a quick comment about your question about the combining the ultrasound and fluoroscopy for cervical root. I do it, and it helps you to, as Barry mentioned, to exclude the intravascular position of the needle because you see the spread of the contrast, but also it will give you the information, are you seeing the epidural spread or like extraforaminal spread. So just for the medical legal, you got the record how you see the inner nerve, and I usually one pictures after the pulse radio frequency. You don't do it before because you change the lesion size when you do the contrast before. So actually it's sort of like some addition, but very important for this reason. And also I like on your pictures because you said this is not the office-based procedure because as you see on the pictures, you're very close on the very vital structures. So the patient with the cannula in hand is very important to get the basic monitoring and IV access in case, because if you just inject into vertebral artery 0.1 or 0.2 million local anesthetic, I'm not mentioning the particular steroid, the patient will get the seizures and lose consciousness, so you need to be prepared for this. So that's very important.
All the cervical procedures, even the extraforaminal, maybe took 1 or 2 minutes to put the needle on C5, C6 5%. I did this procedures inside the OT, inside the theater, with full equipped, ventilator, realistic machine, IV access, everything, and for shock. Because here, as the doctor said, any intravascular injection, even by skeleton, may due to catastrophic and death. So here, in the cervical, we treat with the spinal cord, with the brain, with the vital vessels of the human being. So should be done inside the theater, not in the outpatient clinic.
Sorry. Do you use multiple levels at the same session?
Yes, yes.
Also, and the second question, what is your long-term results with pulsar? 3 months,
If I using
6
alone pulse radio frequency or with the steroid?
No, pulsar.
Just pulsar.
Yes.
Pulsar that depend to the pathology, to the nerve, to the type of the pain. It is the complex pain, for example, ribs. It is the simple pain. It is the neuropathic pain. So much sensitive, so the receptive pain does depend to the type of the pain. But at least the pulse radio frequency, for example, for neurology, I use just pulse radio frequency, no injectate, no steroid, no glycerol, no any chemical irritant materials. I got through the fluoroscope, through the foraminal valley, and reach by motor sensory function. I can reach to the V1, V2, V3, depending to the level of the pain, and do just pulse radio frequency in 2 cycles, each cycle 3 to 4 minutes, and that's it, and remove the needle. The patient back to me 6 months, 1 year, and more than 1 year. Very rarely the patient return back after 1 or 2 months, say I have the pain back. That depends to the psychology of the patient, the history of disease, and the time of the chronicity of the pain. Okay, thank you.